Hello, everyone, and a warm good morning from US. Here I am, Rifat. I'm in Philadelphia. I have with me Emilio, who is in Boston, and it's 8 a.m. Eastern Time. And wish you all a very happy New Year. And thank you so much for joining in. Today we have our first podcast of the year. And in fact, this is the second IPNA podcast. And today we will have as a speaker Dr. ROMIL Saxena, who is professor of pathology at Indiana University. And she is going to talk about liver pathology. Let us start with the basics. And a special shout out to the residents in Mount Sinai. Wish you all a very happy New Year. Hospital, they are actually watching. Thank you so much for joining in as their morning. Today we have. Thank you so much for first podcast doing that, and thank you all for joining with us today. Over to you, Dr. Saxena.
Hello, everybody. Hola, marhaba, shalom, namaskar, salam, ciao. It is quite magical, actually, to be able to connect instantaneously and simultaneously with all time zones across the globe. And to those who are joining in at some forsaken hour, I feel your pain. And I'm also touched by your confidence that this is all worth it. A special shout out to Rifat and Emilio for harnessing the affirmative power of technology, and to IPNA, the Association of Indian Pathologists in North America, for giving me the opportunity to connect with hepatophiles everywhere, whether they are committed, nascent, budding, or otherwise unclassified. When we look at liver biopsies, we are usually taught to first and foremost look for adequacy, and secondly for the architecture of the liver. So I will start with the architecture and talk about adequacy a little bit later on. Now, if you open a chapter or a textbook on liver pathology, you see graphics that look somewhat like this. And we are told that the liver is made up of hexagonal lobules, which have the portal tracts at the periphery of these lobules and the central veins in the center. So this is the lobule as we know it. We are also told that the liver is organized as acini that look like clusters of grapes. This was first described by Rappaport, and that each acinus is divided into 3 zones, zone 1, 2, and 3, zone 1 being closest to the portal veins. We also see figures that talk about a primary lobule that has been described by Matsumoto, and he talks about a sickle cell zone, which is abutted against the portal tract, as over here, and a radial zone that goes towards the central vein. So armed with this exquisite knowledge of liver architecture, we start looking at liver biopsies. And this is what we see. Well, where are those lobules and where are the acini? The fact of the matter is that the liver has very little fibrous tissue, which is limited to the portal tracts and the central veins. And you see that in the strichrome stain, where the blue highlights the central veins or the portal tracts. The lobules and the acini and all the other structures that we see in the nice graphics are not really highlighted by fibrous tissue. These are basically functional divisions that are evident only when we study certain functions of the liver, for example, the enzyme distribution or the vascular flow. By and large, when you look at a liver biopsy, it is a big sea of pink because the liver is basically made up of loads and loads of hepatocytes punctuated at regular intervals by portal tracts and central veins. Now, the zonation or the other structures of the liver do come into view in pathophysiological processes. For example, over here, we have an example of acetaminophen or Tylenol toxicity, and you see how it is a very zonal distribution. So the coagulative necrosis that we see here is present mainly around the central veins in zones 3 and 2. The asterisk marks the central veins, whereas the hepatocytes around the portal tracts are viable and non-necrotic. And this this pathological process brings about the hexagonal lobule into view. Now, so when we talk about the architecture of the liver then, and we see something like this, it's very easy because we know that this architecture is a normal. Because we see the fibrous bands, we see bridging fibrosis, and we see here the formation of nodules, so this is cirrhosis. But what happens if we do not have fibrous tissue and the normality or otherwise of the liver architecture cannot be determined? Well, in that case, it is very important to look for the presence of central veins and portal tracts occurring at a regular interval. So here we have a biopsy which is all pink. There is no fibrous tissue that we can see. So is this architecture normal or is it not normal? Well, if you look at it, you do not see the recurring pattern of portal tracts or central veins. But what we do see are thick-walled vessels. So we see these arteries over here. There's another arteriole over here. But there are no real portal tracts. So this cannot be the normal architecture. This is abnormal. And it turns out that this was a biopsy taken from a mass lesion. And therefore, this is a hepatocellular adenoma. This is not normal liver. So what I'm trying to get at is that when we are assessing the architecture of the liver and we try to see whether it's normal or abnormal, you cannot rely on the graphics that we have seen because those are not highlighted on an H&E stain. So what we are looking for is the regular occurrence of portal tracts and central veins in the biopsy. So here is another example of a core biopsy of the liver. And the first thing we would want to look at besides the adequacy is the architecture. So now if we look at this, we see that it is a whole body of pink without any fibrous tissue, but that does not mean that it is normal because there are no portal tracts occurring at regular intervals. There are some of these vessels. There are no thick-walled arterioles as we saw in the other slide, and this turned out to be a regenerative nodule in a patient with cirrhosis. So to emphasize, when we're looking at the architecture of the liver and there is no obvious fibrosis, how do we determine if it's normal or not normal? Well, make sure that we look for the presence of portal tracts, some of which might be really small, that occur at regular intervals. So once we have looked at the architecture of the liver, we then start examining the other structures. And we look at the portal tracts, which are also sometimes called the portal triads. Now, why is it called a portal triad? Because there are three structures that run in the portal tract. The first is the portal vein, which is a thin-walled structure. Sometimes the very small tributaries may not have much in the wall, and there is just this endothelial lining. There is the hepatic arteriole, which is right over there, and then we have the bile duct. Now, the bile duct, the smallest tributary of the bile duct, is made up of cholangiocytes. And these cholangiocytes are very uniform. They look exactly like one another. They sit very decently next to each other without, getting into each other's way. And this is an appearance that has been called a rosary bead appearance by the religious, or the pearls on a string by the fashionista. So this is a normal appearing portal tract or a portal triad. Now the question is it always a triad? And in a very elegant study done by Dr. Crawford, with some very meticulous counting, they found that dyads are quite as common. In other words, about almost a third of portal tracts will not have a portal vein branch or a tributary. 7% of portal tracts will not have bile ducts, and about 9% will not have a branch of the hepatic artery. It is also common to have multiple profiles. So the portal tract might show you two profiles, each of the hepatic artery and the bile duct. Also, the hepatic artery and the bile duct travel together. The reason is that the hepatic artery is the sole supply of the biliary system. The other thing to remember is that the hepatic artery and bile duct are almost equal in size, with the bile duct to hepatic artery ratio of 0.8 to 1, meaning they're almost equal. The hepatic artery might be just a smidgen larger than the bile duct. Now, why is this important? Because very often we are asked to comment on loss of intrahepatic bile ducts. So here, for example, is a portal tract, and we have two profiles of the arterioles, and there is the portal vein. Now, these two profiles, as I just told you, could be normal because dyads are normal, and there may not be a bile duct in the portal tracts. In about 7% of portal tracts, we do not have bile ducts. So now, is this a pathologic loss of bile ducts, or is this just a normal physiological process? And this question comes up both in the transplanted as well as the non-transplanted liver. So in children, we are asked to make an estimate or give a diagnosis, for example, of Alagille syndrome, which is marked by absence of bile ducts. In transplanted livers, loss of bile ducts is an indication of chronic rejection. Loss of bile ducts may happen with a wide variety of drugs. So when we have a loss of bile ducts, is this normal or is this a pathologic process? And this becomes an issue because about 7% of normal portal tracts may lack bile ducts. And therefore, we have these criteria that to call something a ductopenia or a loss of bile ducts a pathologic process, we need to have at least 50% of portal tracts without bile ducts. We also call them unpaired arterioles because, as I just said, arteries and bile ducts run together. And if you don't have the bile duct and there's just a single arteriole, it's an unpaired arteriole. So 50% of portal tracts without bile ducts and at least 10 portal tracts in the liver biopsy is essential before you can call anything a ductopenia. And again, this is because a small number of portal tracts may have unpaired arterioles in the normal liver. Now, I just told you that the bile duct and the hepatic artery are very similar in size. And what we see here is a hepatic arteriole that is much larger than the bile duct, and it also looks very dilated. Now, this is a case of extrahepatic portal vein thrombosis. And here is a portal vein which shows a muscularization of its wall. Remember, I told you that the portal vein is usually a very thin wall structure. You don't really see much in the wall, but this one actually has muscle. It turns out that these are features of portal vein thrombosis. And the liver has a very smart vascular system. Although the majority of the blood supply is through the portal vein, if there is thrombosis of the portal vein or if there is a decrease in the blood flow, the the artery, the hepatic artery, tries to compensate for this by increasing the blood flow. This is known as the hepatic arterial buffer response, and it is something that has been shown both in animals as well as humans during surgery, but we have never really looked at it pathologically. But here is a fine example of portal vein thrombosis, which is extrahepatic. I know that this is not thrombosed, but the extrahepatic portal vein was thrombosed, and there are effects in the portal vein within the liver. And the hepatic artery here is thickened and dilated. So we did a little study where we used this principle of equality of the sizes of the hepatic artery and bile duct, and did some complex measurements of the hepatic artery relative to the diameter of the bile duct in patients with extrahepatic portal vein thrombosis. And we published this paper where it was the first time that we showed pathologic evidence of hepatic arterial buffer response in the non-cirrhotic human liver. And what was interesting is that this is Dr. Natalia Rush. She was a fellow with us. She did all those complex measurements that I just showed you. And she actually got an award for this paper at the United States and Canadian Academy of Pathology at USCAP. She got the Clark and Stout Award. And the reason I'm emphasizing this is because in a world of molecular pathology, where that seems to be the last word on everything, they actually have an award which commends the study of basic H&E sections and is awarded for scientific medical problems that can be resolved by studying their anatomic features. So sometimes just looking at an H&E can tell us a lot about the pathophysiology of the human body. Now, continuing on with the portal tracts, one must always keep in mind when looking at a liver biopsy that the portal system is like a branching tree. And although we expect to see perfect cross sections of the portal tracts in our biopsy material, it is entirely possible that the biopsy needle has gone this way or that way, cutting a portal tract either at its branching point or in a longitudinal fashion. So here, for example, is a liver biopsy with a portal tract that is going Y-shaped fashion. This is not bridging fibrosis. This is simply a branching portal tract. You see that there are these two portal veins. This is the portal vein that's sort of branched this way. The bile duct has also branched in these two directions, and then we see the hepatic artery. So this is simply a branching portal tract. It's not bridging fibrosis. This was a patient with hepatitis C. You can see the lymphoid aggregate right here. There was no interface hepatitis, and it would be quite wrong to have labeled this as a bridging fibrosis when this was just a branching portal tract. Here we have another liver biopsy in which we have this fibrous tissue going across the entire core. This again is not bridging fibrosis. This is simply a very large portal tract that has been cut longitudinally. And I say longitudinally because you see how all these structures, the bile duct, the hepatic arteriole, as well as the vein, are running in a longitudinal fashion. They have not been cut in cross-section. This was a patient with hepatitis C, and as usual, we were asked to grade and stage the disease. And here we see this blue that's running across the biopsy. And at a very low power, we might be tempted to call this bridging fibrosis, but look at it under a high power. So this is what I'm looking at on the H&E, and you see how all these bile ducts and the portal veins are running in a longitudinal fashion. So this is, and here's another portal tract that's running longitudinally, and it corresponds to this one here. So we have two longitudinally running portal tracts across this biopsy, and this is not bridging fibrosis. So therefore, one has to avoid the overdiagnosis of fibrosis. Be mindful of the fact that you may have large and or branching portal tracts in a liver biopsy. You might have portal tracts that have been cut longitudinally. Another a trip for diagnosing fibrosis is subcapsular parenchyma. So here is a wedge biopsy. This was the capsular surface, and you see how under the capsular surface you have these large bridging septa and the formation of what look like nodules. Now this is not bridging fibrosis or cirrhotic liver. When we look at subcapsular liver biopsies, we have to be mindful that what's immediately under the capsule, up to about 3 to 5 millimeters, is not always representative of what's happening in the deeper parenchyma. And one has to avoid overdiagnosis of fibrosis. There's a very elegant paper, it's by Peter Schroyer, where they looked at this phenomenon. They looked at wedge biopsies, and they found that it is quite common to have bridging fibrosis, what looks like bridging fibrosis and cirrhosis right underneath the capsule. They also showed that this increases with age. So it's much less common to see that in younger patients, but much more common to see it as one ages. The other trip over for overdiagnosis of fibrosis is large areas of collapse. So here we have a biopsy, which might be either, this usually occurs with autoimmune hepatitis or with drug-induced liver injury, where you might have large areas of parenchymal collapse and extinction. So here's a portal tract. There's another portal tract possibly over here, and everything in between seems to have disappeared. And this is what we call parenchymal collapse or extinction. And you see how this looks pretty blue. Now, it's not as dark blue as the collagen that one sees in portal tracts, but at a low power, you might mistake this for fibrosis. But actually, when we look at it on a high power, we see that this is really just collapsed parenchyma. It's not fibrosis, it's just collapsed parenchyma. And so one has to be mindful in cases of severe hepatitis with areas of collapse not to overdiagnose fibrosis. So moving on then with other aspects of fibrous tissue in portal tracts. Portal tracts, as I just showed you, come in all shapes and sizes. And this is the classic textbook example of a small portal tract where you have very little fibrous tissue and small structures, the bile duct, hepatic arteriole, and the portal vein. But remember that in the liver, you will also have large portal tracts. And here is an example of a large portal tract. A large portal tract will have a large bile duct, for example, this one. And a large bile duct is entitled to have more fibrous tissue than a small bile duct. So this collar of fibrous tissue around this large bile duct is perfectly legitimate. This is not fibrosis. And this is important because there is a condition, as you all know, called primary sclerosing cholangitis, which is defined by the presence of periductal fibrosis. And it is important to remember that large bile ducts can have a lot of fibrous tissue around them, and that every time you see this, it is not primary sclerosing cholangitis. So how do we differentiate between primary sclerosing cholangitis and what is normal? This is a normal large bile duct with the fibrous tissue that it's entitled to. Whereas this is primary sclerosing cholangitis in its active stage. And you see that there is a concentric type of fibrosis and concentric inflammatory infiltrate around the bile duct. Now, you might say that it's all very well if you have the inflammation around the bile duct. That's easy to distinguish. What happens when there is no inflammation? In other words, when it is an advanced stage of primary sclerosing cholangitis, when you do not have the inflammation and you just have the fibrosis, for example, over here. So this is primary sclerosing cholangitis. This tissue is abnormal. And you see that there is too much fibrous tissue relative to the size of the bile duct. The other thing that I want to remind you is that if you look at these cholangiocytes, they look pretty damaged. Here is the normal bile duct that I showed you earlier. I talked about the rosary bead or the pearls on a string appearance. And you see how they're very uniform cholangiocytes. Here we have cholangiocytes that are irregular, that are hyperchromatic, and that are not respecting the space between each other. There is some overlapping of nuclei, for example. So when you have primary sclerosing cholangitis, not only is there fibrosis, but there is also abnormalities of the nuclei or biliary epithelial damage. And that is how one would distinguish primary sclerosing cholangitis from a normal bile duct with a lot of fibrous tissue that it's entitled to. You see how these cholangiocytes actually look very normal and very, very uniform. Now, moving on to some of the other things in a prototract or in a normal liver biopsy, we know that one of the main functions of the liver is to produce bile. And bile is drained by the biliary system. The bile ducts coalesce and form lighter bile ducts. It is then drained into the gallbladder and goes into the small intestine. But bile is made here in the hepatocytes. And the question is, how does it get from there to there? Well, the answer lies in these pictures. So here we have the two hepatocytes next to each other. They are the ones who make the bile. The bile is first secreted by the hepatocytes into these tiny structures called the bile canaliculi. And they are all of 1 millimeter in diameter, really, really small. This is an equivalent electron micrograph of the bile ductules, or I'm sorry, of the bile canaliculi. We have the two hepatocytes sitting next to each other. Now, hepatocytes, as you will see, because these are very, very active cells, they're little busybodies. They have a lot of mitochondria. They have a lot of endoplasmic reticulum. They have a lot of glycogen. Here is the Golgi complex. And this is the little bile canaliculus. The bile canaliculus is thrown into a lot of folds, into microvillus folds, just to increase the surface area for all the physiological action that's going on. The other thing is, you notice how the bile canaliculus is sealed off by tight junctions. So over here, it is sealed off by tight junctions because you don't want this bile to get into the bloodstream. For example, because here we have the sinusoidal space and the perisinusoidal space. And we don't want the bile to go in there because bile is a highly noxious substance. So the bile canaliculi are sealed off by these tight junctions. Now, the bile canaliculi form a network of a network that looks like a chicken wire appearance, drains into these structures called the canals of Herring, and then into the little interlobular bile ducts. And although we don't see all of this on a routine H&E, we do see these structures when we stain immunohistochemically for biliary cytokeratins. So this is a stain with cytokeratin 7, which is a biliary cytokeratin. And here you begin to see the ductules, you also see the canals of Herring, which are structures that are lined on one side by cholangiocytes, on the other side by hepatocytes. And so these cholangiocytes are lit up by the biliary cytokeratins. Also, the bile canalicular network in the lobule can be highlighted by immunohistochemical stains using antibodies to antigens that are present on the bile canaliculi. So some of the antibodies that we can use are those against polyclonal CEA, CD10, vilin, and they will highlight the bile canaliculi very well. Now, sometimes on the H&E, you can actually see everything that I was showing you on the immuno or on the graphics on the H&E stain. And here, for example, you see the bile canalicular network. And this dark purple thing here, these are the tight junctions. So you see the bile canalicular network. And in this particular instance, there is cholestasis. So there is actually bile within these bile canaliculi. And sometimes if the conditions are just right, the staining is right, the metabolic state of the hepatocytes is just so, you might actually see these bile canaliculi even on a H&E stain. Now, I don't want to go into the details of this, obviously, but this graphic is just to tell you that those tiny bile canaliculi are really, really busy 24/7 because formation of bile is an energy-dependent, active process. And there are lots of little alphabets that sit on this bile canaliculi that are busy pumping all sorts of complex chemicals to form the bile. And if there is a mutation in any one of these, you can have some really bad diseases like progressive familial intrahepatic cholestasis. And in adults, heterozygous mutations in some of these can give rise to drug-induced liver disease. And I don't want to say give rise to, but it is now being found that mutations in some of these transporters are the cause of drug-induced liver injury that we see quite commonly in adults, drug-induced cholestasis specifically. Now, just to go back to this diagram just for a very little bit, this is methylene blue preparation that's done before doing an EM. And we talked about the bile canaliculi between the hepatocytes. The other side of the hepatocytes, the basolateral aspect, faces the sinusoidal lumen. And the sinusoidal lumen has these stellate cells. Over here, for example, there are the Kupffer cells. And the stellate cells are the ones that are responsible for a lot of fibrosis that occurs in the liver and pathological processes. They also store vitamin A, and they show these little lipid vacuoles because vitamin A is a lipid-soluble vitamin. And if you look at this 1 micron thick section stained with methylene blue, you see these little stellate cells with the little lipid vacuoles. These are the vitamin A storing cells. They are also the cells that give rise to fibrosis. And these are also sometimes called the ETO cells. And here we see the sinusoidal endothelial cell. So this 1 micron section is quite, it highlights all these other things that we seem to know only conceptually. Now, a few other interesting facts about the normal liver biopsy. This is the central vein or the central venule. Around it, the hepatocytes might store a brown, dusty pigment, and this is lipofuscin. So when you see a brown pigment in the liver, if it's present around the central vein, it's lipofuscin. If it's present around the portal tract, it's hemosiderin. Now, the lipofuscin is a wear and tear pigment. and it increases with age. So here on this panel, we have another liver biopsy. You see the central vein. You see that there is much more pigment over here. This is probably an older patient. And also to go along with that, we have cells that are binucleated and multinucleated. And binucleated and multinucleated cells are usually seen in older patients. So this sort of goes hand in hand. It's not only in older patients. I just want to say that you might also see these multinucleated cells sometimes as the effect of drugs that block the mitotic activity of hepatocytes, for example, methotrexate. So binucleated and multinucleated cells are commonly seen in patients who are on methotrexate. Now, the other thing that we might see in a normal liver biopsy are these glycogenated nuclei. We always talk of glycogenated nuclei as being increased in diabetes or other cases of non-alcoholic fatty liver disease. But to remember, one must remember that these are pretty common in children up to the age of, and in teens up to the age of 15 years. There is a nice paper that has shown this by Bob Golden in London. They actually looked at liver biopsies for these glycogenated nuclei and found that these are pretty common in young adults, in children and young adults up to the age of 15 years. Now, in this panel, we have a portal tract with a lot of cells in it, and including what look like eosinophils. We also have these cells within the sinusoids. Now, almost everybody gets tripped upon by these once in their lifetime. We call this hepatitis, but actually this was a patient, this was a pediatric patient, and it's very common to see extramedullary hemopiesis in the very young patient. So do not call this hepatitis. This is just extramedullary hemopiesis. These are myeloid precursors. And over here we have erythroid precursors. It's very, very common for us to get biopsies from very young children for cholestasis. And we see this, and then we might call it hepatitis, but please refrain from that and think about extramedullary hemopiesis, which is pretty normal. Now, I just want to talk very briefly about special stains. So the trichrome stain, I've shown you this picture before, and it's used for staging fibrosis. Now, this fibrosis, this one is bridging fibrosis. Here we have cirrhosis, and we have a whole spectrum of fibrosis as it begins around the portal tract, begins to bridge, and then begins to form cirrhotic nodules. So this is portal-based fibrosis, which is commonly seen in cases of hepatitis or in cases of chronic biliary disease. On the other hand, when we have fatty liver disease, whether it's alcohol or non-alcoholic, the fibrosis tends to begin around the central vein, not around the portal tract. And you see this very peculiar pattern where it tends to creep along the sinusoid, something that we call perisinusoidal fibrosis. This is another example of the same thing. It is a case of non-alcoholic fatty liver disease, and you see how there is this fibrous tissue that is creeping along the sinusoids, what we call perisinusoidal fibrosis. And as you will recall from my earlier slides, that there is very little fibrous tissue in the normal liver. So this is very abnormal, and it has a different distribution from portal-based diseases. This is a case of severe perisinusoidal fibrosis. And when you see this, one must usually think of alcohol. Alcoholic liver disease gives rise to the severe, hard perisinusoidal fibrosis. And the other instances where I have seen this pattern is with some rare metabolic diseases. For example, copper storage diseases is one thing that comes to mind, and other rare metabolic diseases. Now, the reticulin stain is a fantastic stain. And I just want to quote Dr. Geller. He always says that the trichrome is beautiful for taking pictures, but it's the reticulin stain that usually gives you the most information. I will also add that the reticulin stain is a very difficult stain to do. Not every lab gets it correct. I am fortunate that my lab does a beautiful, beautiful reticulin stain. So this is the normal reticulin stain in an adult. Mostly you see one cell thick plates. This is a central vein, and these plates sort of radiate out towards the portal tracts. In a child up to the age of about 5 years, the hepatic plates tend to be 2 cell thick. So when you see this pattern, you can look at a biopsy, and if you see this, you can say, oh, this is a child under 5 years of age. So the reticulin pattern is quite different in a child under 5 years of age. The reticulin pattern will very nicely show small areas of cell loss, what is usually called reticulin condensation or reticulin collapse. And so here we see this reticulin condensation, and this is where cells were lost. In other words, that there was some sort of hepatocellular damage. And you might not always pick that up on an H&E, or if you do pick it up on an H&E, it's very well confirmed by a reticulin stain. And here we have an adult liver biopsy. You see thick cell plates, and this is indicative of regenerative activity in the liver. So there has been some damage, and now there is regenerative activity. And finally, the reticulin stain is extremely, extremely useful for the diagnosis of hepatocellular carcinoma. It is the best stain, in fact, for the diagnosis of hepatocellular carcinoma. And what we see here are thickened plates. But I think it is more appropriate to call this pattern a reticulin poor pattern. So if we have a tumor and we are wondering if this is a hepatocellular carcinoma or not, you do a reticulin stain. If you see a reticulin poor pattern, you can be quite confident that this is a hepatocellular carcinoma. We use it diagnostically all the time. And finally, the reticulin stain is very useful to show whether fragmentation of a liver biopsy is due to the procedure or due to advanced fibrosis. So here we have 2 fragmented liver biopsies, and you can actually see some increased fibrous tissue over here, and it looks like this fragmentation might be due to increased fibrosis. However, this can, on this side, you do not see the fibrous tissue, but you're not sure that is this due to advanced fibrosis or is this due to just the procedure. The reticulin stain has always helped me in making that distinction. So here we have a reticulin stain that shows a very, very normal pattern. And this makes me think that this biopsy was fragmented because of the procedure. Whereas I look at this one and I see a very abnormal reticulin pattern, and I then, coupled with the trichrome stain, I'm then quite confident that this is actually a case of advanced fibrosis, meaning bridging fibrosis or cirrhosis. And one fun fact about the reticulin stain, a well-done reticulin stain, is that reticulin fibers, which is collagen 3, is stained black by the stain, whereas collagen 1 and 4, which is the one that comes up blue on the trichrome stain, is stained brown by the reticulin stain. And that does help me sometimes when I'm looking to see if there's real fibrosis or just reticulin condensation. The color of the reticulins, of the fibers is different. But you do need a very well stained slide for that. The ion stain, or the Pearl's Prussian blue reaction, as you know, hemosiderin comes up nice and blue, or the Prussian blue color, and it stains iron, which you can see on an H&E stain as brown pigment that is refractile. So I've taken this picture with the condenser down to show the refractile structure, refractile nature of iron. But the best use of iron to me is to detect the presence of bile, because bile is rather amorphous, lightly green stained material on your histologic preparations. And you may see that on an H&E, but you may not, because the staining is rather subtle. So you pick up the iron stain, and if there is not too much iron, if there is very little iron, the bile actually comes out very nicely on the Pearl's Prussian blue stain. Of course, there is the Hall stain for bile, but I don't think that there are very many labs that do that stain, and I just did this one for demonstration purposes. Now, another favorite stain is the PAS stain, and it stains all hepatocytes this nice magenta color. But if you step back and think about it, it's really a useless stain because hepatocytes, we know, are full of glycogen and they stain magenta with the PAS stain. So what? That's what's expected. It doesn't tell us really anything. But when you do the diastase, that's when it begins to have some sort of value because now the glycogen is all digested and you can see other material that might be deposited in the hepatocytes. So this is a classic example of alpha-1 antitrypsin globules. That's not glycogen, so it doesn't get digested with the diastase, and it comes up nicely on the PAS diastase stain. The PAS diastase will also show you the material that is stored in Gaucher's disease. We do not get a whole lot of biopsies, so this is a very ancient slide. But again, it's a place where PAS diastase stain has some value. The PAS diastase stain is extremely valuable to me in cases of a very mild resolving or ongoing hepatitis. So if you get a liver biopsy of a patient who has mildly elevated transaminases and it looks pretty much normal and you're scratching your head as to what's going on, pick up the PAS diastase stain, and if you see clusters of macrophages that stain positive, there is a very mild underlying hepatitis going on, which explains the rise in transaminases. And what these things stand for are macrophages that have eaten up one or two dead hepatocytes over here. In other words, there was mild hepatitis, there was some damage to hepatocytes, and they have now been scavenged by these macrophages. So these are like little tombstones of dead hepatocytes. It helps you to explain the transaminases. It helps you to tell the patient that, okay, there was something going on, but it's very mild and you don't need to worry about anything anymore. Finally, there is the rhodonine stain, which stains for copper. The other stain that is quite popular, at least in Europe, is the Orsine stain, which stains copper-associated protein. We don't do that very much in my laboratory, so I don't have a very good picture of that. So the copper stain is very often requested by the clinicians for Wilson's disease. What I want to caution about is that the absence of copper in a liver biopsy does not rule out the existence of Wilson's disease. So just because we say that the copper stain is negative does not exclude that the patient has Wilson's disease. Copper is also present in periportal hepatocytes in chronic cholestatic diseases, so primary biliary cirrhosis, primary sclerosing cholangitis, or any other cause of obstruction to the biliary tree will give rise to copper in periportal hepatocytes. Now, finally, I want to talk about adequacy of liver biopsies, which is something we are always told to comment on. So what is an adequate liver biopsy? Most data that is available in literature derives from biopsies for chronic hepatitis. And these papers describe adequacy either as the minimum number of complete border tracts, and some papers say that 6 are enough, others say that you need at least 11, and or the minimum length of tissue cores. So you need a core that's at least 1 centimeter or 1.5 or 2 or 2.5. And what has been observed is that as the length of the core increases, the inter-observer variation and staging of fibrosis decreases. So the longer the length of the core, the more likely you are to stage it correctly, at least between different observers. And to this, I would like to propose that any biopsy that provides required clinical information is an adequate liver biopsy. And this was important, or this came into sharp relief for us because we were used to getting liver biopsies like this at our institution, nice cores, at least one or two of them. And then at some point, we started receiving liver biopsies that looked somewhat like this. So what was going on here? Well, as you know, liver biopsies are usually taken through a percutaneous route, like over here, or through a transjugular route where one goes in through the jugular vein and then through the hepatic venous system and puts the needle into the liver. And when you do a percutaneous liver biopsies, these are examples that have come across my desk. You get these nice long cores, one or two. Sometimes there might be a little bit of fragmentation. And when we have transjugular liver biopsies, the technique has improved massively over the decades so that we get cores that are quite equivalent to those of percutaneous liver biopsies. These are all examples from our daily practice. Now, here is a new method of getting liver biopsies that is becoming more and more popular. And this is the endoscopic ultrasound guided liver biopsy. So the gastroenterologist is basically doing an endoscopic procedure, going an upper endoscopy. And while he is there, they decided, well, let's look at the liver and let's get a liver biopsy. So they have an ultrasound probe at the end, so they can visualize everything, and they can also stick in a needle. So what is EUS? It was introduced in the 1980s for examination of the pancreas and the gut wall. It was the easiest way to actually visualize the pancreas because the pancreas is really hard to get to. It was then expanded to diagnostic imaging of the liver. Then they said, while we are there, why not take a biopsy? So then they started obtaining biopsies of the pancreas and the liver. And now they have progressed so much that they can actually do therapeutic inventions through that scope that's going down the person's esophagus and stomach. So they are actually able to inject tumors in the liver. They're able to aspirate cysts and abscesses. They even place tips or intrahepatic photosystemic shunts in the liver through this endoscope. This is not widely practiced, but there are people doing it, and I'm sure it will come into the mainstream as more and more practice is gained and the instruments become better. So what are the advantages of this procedure? You can imagine that if you were the patient, you would like it. Why? Because it's two procedures in one session. You can look down my esophagus, you can look at my stomach, and you can do a biopsy while you're there. It's therefore convenient and cost effective. It's one procedure, and the patients are generally more satisfied with that. It is easier in patients with ascites or obesity because you cannot do a percutaneous liver biopsy with these conditions. You can do a transjugular, but there is vascular puncture, but we don't have a vascular puncture with endoscopic ultrasound biopsies. And because there's real-time imaging to target the lesion and avoid large structures. So you're actually looking as you're doing this biopsy, and you will avoid any large vascular structures. You can access multiple sites in the liver. So as you go in, while you're in the stomach, you can access the left lobe. And then if you go in a little deeper into the duodenum, you can actually access the right lobe and, of course, the caudate lobe in between. So in short, this procedure offers better accessibility and high-def visualization. And underrated advantage of EUS is that you can diagnose Helicobacter pylori, because almost always and that's a joke, because almost always when they do a liver biopsy through the stomach or the duodenum, you find a little piece of stomach or duodenum floating among those various fragments. And in fact, it's when you see one of these, besides the fragmentation, you know that it is an endoscopic ultrasound-guided liver biopsy. And so this is what these biopsies look like. And because we started receiving so many of these, and they were all fragmented, and they were a real pain in the neck to interpret because of the fragmentation, we decided to look at our transgastric liver biopsies and see what our experience is with them. And to make it valuable, to give this whole study value, we decided to compare the transgastric liver biopsies with control groups, taking 100 consecutive percutaneous liver biopsies and 100 consecutive transjugular liver biopsies. And if you look at this table, which is, I'll just point out the highlights here, what we were looking at is the adequacy for diagnosis. That was the whole purpose, that are these biopsies adequate for what we want to tell the patient? So if you look at the bottom line first, you see that these are the 100 percutaneous liver biopsies. These are the 100 transjugular liver biopsies. And you find that the adequacy is 100% over here and 98% over here. So very, very good. But when we look at the EUS biopsies, there were 3 needles that had been used in our institution over the years. We find that the adequacy is much lower. In other words, we are not able to tell the patient what, to give the patient relevant clinical information. And so going back to the traditional parameters of adequacy, we looked at the length of the longest core. Now you will remember that these are very fragmented biopsies. And so there might be numerous cores. For example, in these biopsies, more than 10 cores were present in almost all of these cases, whereas in the percutaneous and the transjugular, there were very few biopsies with more than 10 cores. So in other words, these give you these very fragmented cores. But when we started looking at the length of the core, because remember, all the traditional papers have talked about the length of the biopsy core as being very important for adequacy, we found that the length was definitely less in these EUS type of specimens. So 12 to 13, 12 over here, and it's only 8. And then when you look at the number of complete portal tracts, because that's the other criteria for adequacy, you find that the number of complete portal tracts is actually not much less than what we see in the percutaneous and the transjugular liver biopsies. So what this table shows you is that the adequacy of the EUS biopsies is definitely less. But it's not because of the number of portal tracts, because they're getting a large number of portal tracts. And in fact, some of these biopsies had almost 85 portal tracts, so large number of portal tracts. But what is really important is the fragmentation, that when you have fragmented liver biopsies, no matter how many portal tracts you have, or having a good size core is not the only thing that allows you to make a diagnosis. To make a diagnosis, you need a good sized core and non-fragmented specimen. Having said that, we were actually quite surprised that in 30 of the 35 cases out here, this is the most advanced biopsy needle that they have, we were actually able to make a good clinical diagnosis, including the staging. we were very happy with what we had done. So this was also a little bit unexpected for us. And with that, I want to thank you for tuning in, and I hope this has been useful to you.
Thank you again. Thank you, Dr. Saxena, for this excellent lecture on the interpretation of liver biopsies. I was looking online to see if we have questions from anyone. I don't see anything much here, both on YouTube as well as Facebook. But I have one question from myself. So just regarding the approach that you say that it's either percutaneous, and recently they have started using ultrasound guided liver biopsies. So how often, which of these two procedures are more regularly practiced at your institute? And do you have any personal preference for one or the other?
No, well, it's still the percutaneous is definitely more prevalent, but we are seeing many more endoscopic ultrasound biopsies, and I think the techniques are improving. So I think that there's going to be an exponential increase in these.
Okay. Okay. Thank you. Once again, thanks a lot. And I would like to thank all our viewers. And Dr. Saxena, you would be happy to know that we had viewers at this time from at least 33 different countries, from Asia, Europe, North and South America, Africa, among others. And thanks all the viewers for defying different time zones and joining in. And a special shout out to Nasrat and Zakrullah, who joined from Afghanistan, Kibet from Kenya, A4 from Myanmar, and we had Tama from Slovenia. And we also had Dr. Sayama from Mongolia, Sami from Palestine. Thanks a lot, everyone, for joining in. And once again, and we also want to thank Association of Indian Pathologists of North America for giving us this opportunity to host Dr. Saxena today. And as always, please subscribe to our YouTube channel so that you can access to our other lectures. And also please follow our podcast web page on Facebook. And thank you so much. Thank you again, Dr. Saxena, for joining in and for this excellent lecture.